Hi everyone, our subject today is visual impairment in pediatrics. A detailed description of the visual complaint is helpful, but in infant and young children, the history tends to be based primarily on the observations of family and caretakers. For children older, inquire about focal versus general, blurring, double imaging, night vision, and abnormal sensation. Example, spots, lines. The birth history is an important component of the medical history because asphyxia or trauma like forceps injury may be contributory. Recent illness may aid in the diagnosis of sudden visual loss caused by acute optic neuritis. A family history of neurocutaneous disorder, metabolic disorder, cataract, or other visual problems may also be helpful. The examination should include an assessment of visual acuity using a Snell chart or one designed for pre-literate children, tumbling E and picture test. For infants and toddler, referral for visual assessment using behavioral responses may be necessary. Visual fields should also be assessed. Examination of the pupils, ocular motility, and eye alignment is necessary. A thorough ophthalmologic examination should be done. Common findings that may be helpful in diagnosis include strabismus, corneal opacity, leukocoria, and nystagmus. How to approach a child with visual impairment after performing history and physical examination, visual acuity, and eye exam. Is that presenting shortly or after birth? Ask about or look for leukocoria. If it is present, this is maybe cataract, retinoblastoma, retinopathy of prematurity, persistent hyperplastic, primary vitreous chorioretinal coloboma. If there is no leukocoria, this is maybe corneal disease, forceps injury, sclerocorneal, anterior microphthalmia, anterior chamber disease, glaucoma, persistent pupillary membrane cortical blindness, iris and lens disorder, retinal and optic nerve disorder, chorioretinitis, retinopathy of prematurity, labor, congenital retinal amaurosis, achromatopsia, congenital stationary night blindness, optic nerve hypoplasia, coloboma, Aicardi syndrome, or albinism. Is there acute onset later in infancy or childhood? This is maybe trauma, hyphema, vitreous hemorrhage, optic nerve injury, uveitis, iritis, optic neuritis, vascular insult to eye or brain, central retinal artery occlusion, migraine, amaurosis fugax, cerebrovascular accident, strabismus due to increased intracranial pressure, retinal detachment, endophthalmitis, or psychogenic. Of course, this is diagnosis of exclusion. Is there gradual onset later in infancy or childhood? Is it corrected by refraction? If it is yes, this is maybe myopia, hyperopia, astigmatism, anisometropia, disorder of accommodation. If it is not corrected by refraction, is there amblyopia present? If it is yes, maybe strabismic amblyopia, anisometropic amblyopia, ametropic amblyopia, deprivation amblyopia. If there is not corrected by refraction and there is no amblyopia, this may include tumors, juvenile glaucoma, acquired cataract, trauma, radiation, steroid, hydrocephalus, diabetes mellitus, disorder causing retinal detachment, degenerative retinal disorder, macular dystrophies, hamartomas disorder, Sturge-Weber syndrome, astrocytic proliferation in tuberous sclerosis, and neurofibromatosis. Recommended investigation: torch screen test with PCR and serological test for cytomegalovirus, herpes simplex virus, and rubella virus. HIV DNA detected by PCR. Orbital ultrasound and CT scan for eye and head for suspected tumor. EEG for cases with seizure. Electroretinography for retinal causes of visual loss. Top tips: eye examination is an essential part of neonatal examination, include using an ophthalmoscope at distance of 20 to 25 cm to look for red reflex. Fundoscopy is usually unnecessary. In ophthalmology, more than in any other specialty, observation is the most important technique to detect abnormality. Get the child interested in visual toys and games such as a bright red object or the light source of torch. Although children with the eye problems are often referred to an ophthalmologist, a clinician should be able to perform certain eye examination. These include examination of the visual field, looking for wiggling finger, corneal light reflex, cover test, and fundoscopy. Visual acuity is tested by the child's ability to fixate on the fellow on object such as a brightly colored toy. The most common cause for transient vision loss in children occur during visual aura of a classic migraine. Aura is defined by the International Headache Society as a recurrent disorder that develops over 5 to 29 minutes and lasts for less than 1 hour. Transient monocular vision loss lasting 1 to 5 minutes is usually referred to as amaurosis fugax, resulting from cerebral ischemia, seizure, or stroke, while migraine aura may present with the flashes of light, photopsia. Amaurosis fugax present as a blackout of vision or a curtain across the vision. Red flags: be aware that a child with leukocoria, a white pupil, has a major clinical implication. The likely cause is either retinoblastoma or cataract. Untreated or with delayed treatment, the retinoblastoma will lead to death and cataract to permanent vision loss. Be aware of long-term use of steroid that can cause cataract and glaucoma. Condition causing sudden loss of vision, migraine or amaurosis fugax, thromboembolic event may occur in predisposed conditions such as polycythemia, sickle cell anemia, and homocystinuria. Be aware that migraine occurring within 1 hour of vision loss is typical for retinal migraine. Any red eyes should not be treated with the topical steroid before herpes keratitis is excluded. Occipital seizures such as benign partial epilepsy with occipital paroxysm are not rare. Visual symptoms are prominent and include amaurosis, multicolored illusion or hallucination, and eye deviation, followed by hemiclonic seizure or automatism. EEG is usually diagnostic. While papilledema is a cardinal sign of increased intracranial pressure in infant, separation of the cranial suture and bulging of the anterior fontanelle decompress the intracranial pressure. Papilledema is not seen. Thank you for your listening.